and we're going to hear from Nancy O'Brien. Nancy O'Brien is a nurse working with the NHS since 1984, dual qualified in both adult and paediatric nursing. The majority of her experience has been in paediatric oncology, haematology and bone marrow transplant nursing. She's got a BSc Honours in Children's Cancer Nursing at the Royal Marsden and a postgraduate diploma in advanced nursing practice along the way. She's worked as a clinical nurse specialist in paediatric haematology for 15 years at St Mary's Hospital before moving to Therapeutic Apheresis services in London, NHSBT in 2015. As the lead nurse for TAS in London, she's been heavily involved with the setting up of the unit, gaining experience in all aspects of apheresis, and is currently a specialist nurse in TAS London, and delighted to see the developments in red cell exchange services in London over the last 7 years. And we're going to hear about shaping the future of automated red cell exchange for haemoglobinopathies in London. Thanks. Over to you, Nancy.
Hi, good afternoon. Thank you for that introduction. Yes, what I want to talk about is shaping the future of red cell exchange within London. My objectives, basically, if we can have an overview of why we need to improve access to automated red cell for patients with sickle cell, share some perspectives on how access to automated exchange might be improved in London going forward, and just consider good practice in the future delivery of automated red cell exchange. NHSBT Therapeutic Apheresis Service is a service delivering care to adults and children with sickle cell, both nationally and in London. Our general philosophy is not to take over apheresis or red cell exchange within London or nationally, but to fill gaps where it isn't readily available, to collaborate with, hopefully, with red cell providers, with hospitals who can't provide or can't robustly provide the service, and therefore improve red cell exchange services to the sickle cell population as a whole. So why do we need to improve access to automated red cell exchange? Well, as Sarah Trumpeter rightfully pointed out, there's 15,000 to 17,000 people with sickle cell in the country, with approximately 300 babies being born every year. And we know the condition is increasing rather than decreasing. So the greater use of automated red cell exchange transfusion benefits patients by reducing the complications of sickle cell, reducing cost of iron chelation treatment, and improving patient access and experience. We know that from data, some NHS data review back even as early as 2015, which was around the time that we set up, basically said that reported that services had improved had generally improved over the last 10 years when it came to sickle cell disease and to automated exchange, but that some people still experience poor care, and it varied throughout the country. So everybody's been aiming ever since then to actually improve access. And we're still questionable. We've still got a long, long, long way to go. It seemed to be moving. Sorry, can anybody help out there?
Yep. Did you want me to move the slides for you?
Yeah, it doesn't seem to be.
Control.
Sorry about that.
That's okay.
Right, so this is a slide about manual versus automated red cell exchange. Traditionally, well in the past, there used to be top-up entrant. The way to actually bring down the S level was basically to do a straightforward top-up exchange transfusion. The idea is obviously with sickle cell, with anybody with sickle cell disease, you want to reduce the amount of sickle cell, and hopefully that will then go forward to improve their situation or their condition. You can then actually do a manual exchange and an automated exchange. And as you can see, there's huge benefits to actually doing automated exchange here. It's basically the frequency of it still remains. You still got to do, the idea is to actually do a routine program rather than having to go in with a patient on an emergency process. You're much more likely to have less morbidity and more mortality issues. And the frequency of the programs can be anything from 4 to 8 weeks. The length of the procedure is much less with an automated exchange. The average units of red cells that are used with a patient is between about 8 to 10 units. This was with an adult. With children, it's around 5. And most importantly here, your blood volume shifts are much minimal, which makes it a much safer process for the patient. And the ability to predict the outcome with regard to hemoglobin S and HB post transfusion is much more accurate with the automated exchange, and iron loading base is much more minimal than the other two there with the other two options. So basically, we come along. We use a Terumo Optia machine. We need to get some sort of venous access, hopefully just by cannulation. Obviously, this could be very difficult, particularly with people with sickle cell disease, who we know have sometimes some quite challenging veins and vascular systems. But if we can, we go in with cannulas. If we can't, then we need to look at other options, such as using VASCATs, which again is not ideal because we can damage veins, larger veins. If we can't use VASCAT, or actually ideally, preferably to use in a VASCAT, if we can use ultrasound guided cannulation and actually get access, and that's much more beneficial for the patient. As such, so we come along with the machine, we attach the patient to the machine, take off their blood in a closed circuit, take off the red cell, exchange the sickle red cell for blood donated cells, and at the same time we're giving patient back their own platelets and their own white cells, so that's not being interfered with. Can I have the next slide, please? So the standards and the guidelines and standards that we've basically used to promote or move forward automated exchange, both in London and nationally, are basically the sickle cell standards back in 2018. They really put forward the idea. This was driven by the Sickle Cell Society. They put forward the idea that because of all these safety issues that I've just spoken about, that every patient who needed some sort of either top-up transfusion or exchange transfusion had the right to have it. And we know that we're not really there with that as yet. Other supporters have obviously been the British Society of Haematology, and there's some key articles or driven articles on that, basically just departing about just how important it is. Next slide, please. We obviously, payment of this is obviously really important, and this has been driven forward by NICE guidelines, and from the guidelines, from what's controlling when we actually step in and actually apheresis patient, we very much try to be driven by guidelines, and the most optimum guidelines that we have is basically the American Society of Apheresis, or the ASFA Guidelines, which is guidelines that's published every 2 to 3 years. They categorise of the most important aspects of when we should actually go in with apheresis or with red cell exchange, and such as chest crisis, or program if the patient's got central nervous has got stroke, is at risk of stroke. So it's a comprehensive literature review. It categorises and classifies the important situations that we should actually go in, and it's a practical recommendations for clinicians, both doctors and nurses. And it's just about the one that's actually prominent at the moment is 2019, but they've actually just published the 2023, although I actually haven't seen a copy. So that's just something to look out for, and it's a useful guideline. Next slide, please. Yeah, so this is the ASFA Guidelines 2019, which you can see here quite clearly. It's very easy to read. This is the Optia, our Optia, Terumo Optia machine. And next slide, please. Yeah, so this is really just about just sanctifying by the patients themselves about why they think it's important to be on programmes and how they've found red cell exchange without their monthly infusions, rather the monthly apheresis. Education would be limited, and it's basically improving their life. If you can move forward. Next slide, please. Who are Therapeutic Apheresis Services in London? As I say, we started back in 2015 with just 2.5 nurses and a part-time transfusion doctor with an experience in both paediatric and adult red cell. We're lucky to have that. We went into meet a need. We were asked to go into Great Ormond Street. That's where we're set up, and they've continued to be our host hospital. We're asked to go in there to actually take over their apheresis services. There's not only red cell exchange that we do. We actually do stem cell collections, plasma exchange, and other apheresis as well. Throughout the years, we've basically grown massively. We've now got 13 nurses, and we're now covering more of London. We very quickly got asked to actually set up SLAs and to collaborate and work with other hospitals. We're quite unusual, unlike the rest of the units within Britain. We actually haven't got a geographical unit as such. We go to the bedside, so we have either machines set in the units, or we take a machine with us, and the nurse goes there, and we will then perform the procedure. Next slide, please. So what we actually do, the slide identifies what we're actually doing now is we have 2 bases which basically work together. Our unit is based clinically at Great Ormond Street still, but we work here at 8 different other units across London. At the moment we're working with Northwick Park, UCLH to do paediatrics. We've worked with the Royal London in the past. We work with North Middlesex as well, and we're increasing all the time. And we've got our offices are based at the West End Donor Centre, so it's very much sort of hub and spoke principle. Next slide, please. This is just a little view of the fact that we're not alone in London. We're actually work across England. There is a total of 9 units from Liverpool, Sheffield, Birmingham, Bristol, which work out of Cardiff and Plymouth. We have around 90 in total of around 90 nurses. We've got something like 10 consultants who work either part-time or full-time or collaboratively with NHSBT and other hospital spokes to actually cover services. All the time we're working to actually improve access for patients. Next slide, please. As I say, at the moment, in the last year, we've actually given 10,000 treatments, that's just not red cell, that's on all the apheresis that we cover, which covers over 15,000, nearly 15,000 patients. Next slide, please. So how does this actually look? So and it's really important that we demonstrate the fact that we work collaboratively with trust and service to provide and improve access to automated red cell for those patients needing both acute and long-term transfusions. Because of the size of ours, we're offering an assurance of robust service with an established national model with in-depth policies and procedures. Unlike one of the things that we do offer, which is quite unique, is out of hours service, emergency services. which, although there are obviously a lot of good units out there, they do have problems from a staffing perspective of offering that out of hours service. And that's one of the challenges going forward that I think needs to be tackled, basically, to improve access for patients. Just a bit, we have regular MDTs with the hospitals that we actually work with. Throughout that time, we actually obviously look at operational issues, business issues, and most importantly, definite patient reviews, looking at how we're meeting their HbS targets, their haemoglobin targets, whether there's been actually any issues during the procedure. The procedures themselves are normally quite straightforward. The only major thing that we need to look out for is citrate toxicity during the actual procedure itself. And that looks like hypocalcemia. In fact, we need to use citrate as an anticoagulant to actually perform the procedure and prevent the blood actually clotting in the machinery. Just looking at our reviews, which is a bit quite hot off the press, with our top score nursing and nursing and medical user satisfaction is around the 87 mark. I'd like to see it go higher, obviously, and a lot of that's about encouraging the service users to actually complete the scores. This is quite off the press to say this year, and some of the views from service users that came back was that they were happy with the service that we provided, but they would still like, although we've worked very hard to improve our referral and smoothline our referral service, they'd like to see the referral service just quickened up as possible. Obviously, it's really important that we get out to the patients, particularly in the emergency setting, as quickly as possible. We have a standard of 4 hours. And the other issues that were still they were talking about as well was actually improving venous access and how we help them with the venous access. At the moment, the guideline or the policy that we work with is that the venous access is still the responsibility of the hospital or the clinical unit that we're actually going into. And obviously, sometimes that can cause them an issue. We obviously come in and do our own cannulation, but quite often, if we can't actually cannulate the patient, we will need help with getting timely assistance with that cannulation, whether it be ultrasound guided or whether it would be having a vas cath put in. And as you know, getting a vas cath in at any time, night or day, is not as an easy process in any hospital at all. Each unit, TAS unit, is fully regulated by the HTA, by JC, and by the Care Quality Commission. As well as, obviously, we have a big quality department within NHSBT, and we have internal regulation as well. There was an annual review of our patient satisfaction survey, which came out last year, which was around the patient satisfaction was about 57 patients, and our family and friend most likely to recommend us was worked at about 87%, and with about 87% with 13% of likely to recommend us, which is very hopeful and very nice of them to say that as well. I mean, we obviously do like to get comments back from them about how we can improve our services. Next slide, please. So I just wanted to look about an increase in demand for services with London. I mean, we know that we need to improve access, but as you can see, since 2015, just how to present day, just how much activity has gone up with automated red cell. And it's gone up with an increase of 88%. And what's really interesting is that 2020 figure. We had a massive increase in 2020, and that was when COVID hit. And obviously what happened with COVID, amazingly, wasn't so much, everyone was really concerned about, obviously, about the sickle cell population and exactly what would happen and how they would be affected. And we were pleasantly surprised. One, the most importantly, with physiologically how they cope with COVID. And in actual fact, they were really good at isolating. They were really good at protecting themselves and actually attending, importantly, for important sessions and apheresis procedures, while protecting themselves and not going to hospital unnecessarily. But the big increases. So we never see we never saw any decrease of our apheresis. We didn't see an increase in emergency procedures at all, because the routine procedures were being handled and the programs were being kept to by the patients. And where the big increase here is from is basically is other units, unfortunately, not being able to carry on such a robust service that they were doing, particularly in routine procedures, because of staffing issues around their own around COVID with their own patients. After COVID, we've seen a little bit of a drop in the number of red cells activity that we that go ahead in London, but that's understandable, and then in fact it's still increasing to what it was previous to COVID, and that's because we've taken on basically we've been asked to collaborate and help with more hospitals, more patients. Next slide. Here we can just see sort of activity, acute red cell activity from 2014 to 2019. And my next slide just describes further as well, which basically just shows just a massive increase nationally. So both in paediatric and adult red cell exchanges. So that is showing that over the years we are improving things, not as just NHSBT, but I think something is working and patients are getting a large amount of patients are obviously getting treated since those very early days, since 2015. Next slide. This is just the later 2019 to 23 activity, and as you can see, there's still been an increase nationally, even with TAS, which shows that if it's happening with TAS, it's happening probably elsewhere as well. Next slide. And this is just a little bit about obviously our red cell usage from 2017, and my next slide shows 2022 to 23, and it just shows the fact of our average use of red cells during the red cell exchange and the numbers of patients. So it will show the fact that the increase with the number of patients, the increase of units that we need, and that's obviously why it's important from the blood side that we're actually getting the blood that we do need. Even during COVID, I mean, we do find obviously, getting blood for the exchanges for sickle is seen as an absolute priority within an HSBT, and we've never been in a situation where we've been told that we can't get what we can't have what we need, and the procedures happen largely on time. That I've never known of a delay, to be honest, unless a patient's had really severe antibodies. Next slide, please. And let's say that just shows 22 to 23, where you can see the increase. If you can just next slide, please. This is just I just wanted to really impress the importance of we can't do red cell exchanges in the way that we do it, because we have our model is to go into other hospitals. We can't do it unless there's absolutely effective and smooth communication between the clinicians who are asking us to go in, and i.e. the doctors and the nurses on the ground who are looking after those patients with sickle cell, who are preparing for us coming into their hospitals. We can't perform the way we do unless we're talking with the blood is ready, that there's effective communication between the blood centres, the delivery of the bloods, the units, the patients, keeping communication with the patients about scheduling. That's amazingly important, and we normally leave the scheduling of the patients and the communication with the patients for that scheduling with the clinicians at the centres, because that's the smoothest way of doing that. Next slide. This is, just talking about communication. This is just a really sad reflection on, back in 2015 or even earlier, it was just identified, and it has been identified along the way, that there's a lot of work that needs to be done to improving access for people with sickle cell to things like exchanges, and it's still a long way to go. This is the No One's Listening report, parliamentary group report back in 2021. It was basically it was an APPG inquiry on sickle cell and thalassemia, which still found serious care failings in acute services as evidence of attitudes which were underpinned by racism, and that's absolutely horrifying to hear in this day and age. We're still hearing this when we were hearing it back in 2015, although it's been identified that things have improved and we've got some evidence that it's improved, but has it improved as much as it could have? The report was jointly published by the APPG and the Sickle Cell Society. It was it basically highlighted and was driven by the death of a sickle cell patient, Ethan Nathan Smith, back in 2019, and basically it's called for major changes in care of for sickle cell patients. And listening to what their needs are, and improving services still, finding the funding and getting the funding out there and improving access to care, full stop. If you could, next slide, please. So I just want to talk about important considerations in today's automated red cell exchange. Basically, as I've already alluded to, it's absolutely the major challenge of timely and safe preparation for acute red cell exchange by all parties. And this is a real challenge when it comes to emergency exchanges. We've tried to slicken it as much as possible by, informing the centres exactly what we need. And we're always impressed by how helpful they are, even the nurses on the ground. I mean, hopefully, in this day and age, quite often, our hope would be that we're going into a hospital or a unit that knows us and that knows what we do and knows what we need. But quite often we find that we're called to go into an area that doesn't know us, and the nurses need a huge amount of education at the time. And before and afterwards. I mean, that's one of our drives. Our standard of care in emergency situations is to get out there within 4 hours, and as I say, and that's can only be done by the really swift moving but with the patient, identifying the patient needs the exchange by contacting us, by contacting blood bank to get the blood over, to get the blood delivered. I mean, it's a huge infrastructure, as you know, of transport links for NHSBT to actually get blood delivered in a timely manner and as much as is needed. That's not without its challenges as well, but I think it's done pretty impressively, to be honest. And when we started in London, the transport, we made use of the transfer infrastructure, and we move our machines around as necessary, and they've taken that on with, as I say, in the same vein that they do the blood deliveries. One of our major issues is basically potential delay in blood issue. If that happens to us, we need to get out there within 4 hours to get the patient connected in an emergency situation. But if the blood's quite often, if there's a blood delay, if there's a delivery if there's a delay in the delivery of the blood or the issuing of the blood, that's what holds us up, and that can be really detrimental to the patient. And it can be really down even to the ground roots of at the time of portering. Who's actually going to go and get the blood? And as we know, in today's with shortages, resource shortages, quite often there isn't a porter around to go and collect. And I've known it when we've had to run and collect it ourselves. We've had to identify a nurse, one that's taken off of other duties to go and get it, or a clinical nurse specialist, or anybody who's around, or even one of the doctors to go and get the blood if there's not a portering around. So all that needs to be thought out basically as we're coming in. The impact, what's really important is that we do keep the patient at the centre of this, and I think that's identified by Who's Listening campaign. And basically, if the patient isn't dissatisfied, this is going to lead to detriment of their care, because they're soon going to get fed up of delays, of not getting the service that they require. That will result in them not carrying on with their programmes, which is going to be detrimental to them from a health perspective, or then turning up late for their procedures, which is going to be detrimental to us then actually serving and providing a procedure for the next patient. Next slide. So just looking a bit at our future initiatives for TAS within London and for automated red cell exchanges. As I've told, we've come a long way with trying to help and improve access for patients to red cell exchange within London and also nationally. But we've had to kind of adapt our models as such to improve that access, and we're trying to carry on doing that. And that's to try and fill the gaps where there's not a good service going on already by other promoters. Recently, sort of an initiative that's been going on, and we're trying to get into London itself, is something called the MedTech initiative, or open access initiative. And very recently, back in December 2022, our Manchester unit has been working very started initiative with the MRI, which is their local sickle cell hub, to basically give smooth the services and sort out monetary streams and funding streams using medtech money, basically, to improve the services to for red cell exchanges out to the regional other hospitals. And they've managed to basically get services out to 13 local hospitals who are covered by the MRI, by the MRI's central red cell service. But the idea is to streamline the whole service, take away the need for those 13 hospitals to have SLAs with NHSBT Direct, because the SLA is with the MRI. The funding is from MedTech. They don't need to worry about the money. All the clinical need and support that they're going to get is from the MRI and their sickle cell hub. And that's over 24 hours, but particularly out of hours after 6 p.m. Or whenever the unit closes, obviously we've got it's early days with that, but the idea is for us to come in and fill where the gap needs, and it's about collaborating with the academic sciences, with the clinical hospitals, just to get the service, and with us at NHSBT TAS to actually get the services out there. I mean, we're in talks within London with King's College to serve South London, and as I say, there's some really good units within South London offering, such as Guy's and King's and Tooting, offering a really good service. Hammersmith, offering a really good service from a routine perspective, but when it comes to emergency perspective, they need support and they need help to do that. So we're in talks, as I say, with King's in the south. We're also out of London. We're in talks with Adam Brooks to actually serve the East Anglia regions and local hospitals who work with Adam Brooks's red cell hub. So we're just hoping that initiative would take off, but that we'll adapt our model to actually fill the gaps where the patients and our service users actually want us to fill that gaps. As I say, what I alluded to before was about the problems with gaining venous access for these patients. And one of the things that we're working on within HSBT is training more of our staff even within London to actually give ultrasound guided cannulation to be trained. So we've got more trained practitioners trained to actually do that, and that's then takes the emphasis and takes the pressure off the hospitals that we're going into, and hopefully will decrease the use of VAS caths, i.e. it will be quicker to actually get the patient on the machine, if nothing else. One of the other things that we need an awful lot of improvement and future work with as well is the use of red cell depletion with our normal processes. We're working very hard within HSB to actually improve or to decrease the number of actual units of blood that we're using, which is per patient, and red cell depletion is an ideal way of doing that. With hopefully our aim would be that with every adult patient we could save at least a unit of blood that could be used elsewhere by actually by safely using saline to replace that extra unit of blood. But it's got to be done in a safe. It's got to be done in a safe manner. It's got to be done for the patient. It's got to be the patients themselves have got to be chosen correctly. So there's still a lot of work and looking at outcomes, and there's a lot of places to do it much better than NHSBT at the moment. I mean, basically, I think this all talked about communication before, but there's also training. One of our initiatives going forward is to basically continually to improve education with our staff, helping to educate other apheresis units as well with the training of their staff. We've just spent a lot of money and a lot of time improving the number of education staff that we've got within NHSB for both internal and external education needs. And within that as well would be to use our resources to prep and to get the message and to help both service users and patients with their trend to increase their access basically to red cell exchanges. Next slide. Please, thank you. So that's just how to connect with us. As I say, we're very keen if we've got the resource and we've got the if we've got resource we can get out to you. We'll be there to actually help bridge a need if it's needed. We never try and leave a patient without red cell exchange if it's needed. We'll utilise if it's not our unit that comes out, it will be somebody else from another unit that will do it within TAS. And the final slide. Yeah, so thank you for listening. And if there's any questions.